Dr. Sakshi Arora. I am author of Self-Assessment and Review of Obstetrics. Thank you for the overwhelming response which you've given to my previous 3 editions. In the 4th edition, we are coming out with a novel idea, and that is a live lecture in obstetrics. The topic which I have selected for today is basics of reproduction. Now, when we talk about basics of reproduction, we will begin with the germ cell. Obviously, germ cell will have a chromosome number of 46, that is, they are diploid. The first question which comes to everybody's mind when we talk about germ cells is the origin of germ cells. Now, there is a lot of confusion about how does a germ cell originate. What I am telling you is what Williams 13th edition page 101 specifically mentions, and it says that germ cells originates from the endoderm of yolk sac. Now, these germ cells, they travel to the genital ridge. Initially, germ cells, they are bipotential in nature. That means they can either differentiate into male germ cell or they can differentiate into female germ cell. This ability, whether they are going to differentiate into male germ cell or female germ cell, that means the sex of the baby is decided by Y chromosome. On Y chromosome, the short arm of Y chromosome has got a region which is called as testes determining factor, or this is called as sex related region. Now, if Y chromosome is present, this means the baby is going to be a male baby. That means the gonads are going to be testes. But if there is absence of Y chromosome, then it means that the baby is going to be a female baby. So, absence of Y chromosome is responsible for a female baby. Now, till 6 weeks, the gonads which are formed, they are indifferent gonads. If Y chromosome is present, I am telling you that the gonads will form testes. Now, these testes, they have got Sertoli cells and Leydig cells. Sertoli cells, they release a factor which is called as the Mullerian inhibiting factor. I'm so sorry for my handwriting, but this is like this over the years. I cannot do anything. This Mullerian inhibiting factor, this is going to inhibit Mullerian duct. Now, you know that a Mullerian duct gives rise to fallopian tubes, uterus and upper part of vagina. Now, when there is Mullerian inhibiting factor, this means neither will there be formation of uterus nor fallopian tubes, nor there will be formation of upper part of vagina. Later on, Leydig cells, they produce testosterone. Now, testosterone, it will promote the development of Wolffian duct. This Wolffian duct in males gives rise to the formation of vas deferens, epididymis and seminal vesicles. Plus, this testosterone, which is formed by the Leydig cells, leads to the formation of external genitalia in males. Coming to the questions which are asked till here. Number 1, question is that ovaries and testes, they can be first distinguished at 8 weeks. Number 2 question is that external genitalia, they can be first identified or they can be first distinguished external genitalia, they are first formed by 12 weeks. But in ultrasound, by inspection of external genitalia, you cannot tell the sex of the baby till 14 weeks. So although they start forming by 12 weeks, by ultrasound, we can tell the sex of the baby by examining the external genitalia by 14 weeks. Now, coming back to germ cells. Now, these germ cells, once the sex is decided, if these germ cells have to form a male baby, they will form spermatogonia. The chromosome number of spermatogonia, as you know, is 46 in brackets XY. Now, spermatogonia, they will then undergo mitosis and they will form primary spermatocyte. Primary spermatocyte, again the chromosome number is 46XY. This primary spermatocyte undergoes meiosis. Meiosis, let us brush our memory. Meiosis has got two divisions, meiosis 1 and meiosis 2. Now, meiosis 1 is a division in which the chromosome number is halved. That means meiosis 1 is the actual reduction division. Whereas meiosis 2, it is very much similar to mitosis and the chromosome number remains the same in meiosis 2. Now, when primary spermatocytes are formed, they will undergo meiosis 1 and so the chromosome number will be halved and two secondary spermatocytes will be formed. So the chromosome number of the secondary spermatocyte will be half of that of primary spermatocyte and it will be 23. In brackets, one will have X chromosome and the other will have Y chromosome. Now these secondary spermatocytes, they will then undergo meiosis 2. And they will form 4 spermatids. As I told you, meiosis 2 is similar to mitosis. Therefore, chromosome number remain same. 23X, 2 of them will have 23X, 2 of them will have 23Y. This process is called as spermatogenesis. Now, once these spermatids are formed, these spermatids, neither will they undergo mitosis, neither will they undergo meiosis, they will simply undergo transformation. This transformation is called as spermiogenesis and they will form 4 sperms. So the chromosome number of the sperms is 23X, 23X, 23Y, 23Y. Coming to the questions which are asked on this. Number 1, when does spermatogenesis occur in males? Remember, in males, this process of spermatogenesis occurs at the time of puberty. That is first question. Second question which they ask here is, what is spermiogenesis? Spermiogenesis is simply transformation. Neither is there mitosis, neither there is meiosis. In AIMS, there was once a question that chromosome number is halved or reduction division occurs at the time of. And then we had 2 options. Number 1 option was when primary spermatocyte is changed into secondary spermatocytes, and the second option was when secondary spermatocyte is changed into spermatids. Technically speaking, both of them are meiosis. This is meiosis 1 and this is meiosis 2. But actually reduction occurs at the time of meiosis 1. So the correct answer is reduction division occurs when primary spermatocyte changes into secondary spermatocyte. Next question which they ask is, what is the time taken for spermatogenesis? The time which is taken for spermatogenesis is 61 days. But then this 61 days is the time which germ cells or the spermatogonia will take to form spermatids. These spermatids, they also travel in the male ductal system. So the time which is taken for spermatogenesis plus the time which they take to travel in the male ductal system, total is 90 days. This fact is important clinically also, because suppose if there is an infertile couple who is coming to you and you find out that there is a problem with the male partner, there is oligospermia or any other problem, you give some medication to treat the male partner. Then at what time should you repeat a semen analysis? So a repeat semen analysis should be done after 3 months, that is after 90 days, because that is the time which is taken for spermatogenesis as well as the time which the sperms take to travel in the male ductal system. This is what is spermatogenesis. This is all we have to know on spermatogenesis. Now based on the same format but with few differences is oogenesis. So coming to oogenesis, it is a process by which a mature ovum will be formed from oogonia. So oogenesis will begin with oogonia. The chromosome number of oogonia will be 46 brackets XX. Now this oogonia will undergo mitosis and it will form primary oocyte. The chromosome number of primary oocyte, because it is mitosis, will remain the same, that is 46XX. Now this primary oocyte will then undergo meiosis 1. But meiosis 1 is arrested. This meiosis 1 is arrested in diplotin stage of prophase. The difference between oogenesis and spermatogenesis is that spermatogenesis begins at the time of puberty, whereas the time at which oogenesis begins is 6 to 8 weeks. Another question. 6 to 8 weeks of gestation, oogenesis begins. But this process of oogenesis is not complete, and at the stage of prophase, in the diplotin stage, meiosis 1 is arrested, and this division, it is completed only at the time of puberty. At the time of puberty, this division will be completed, and what will be released is a secondary oocyte. Chromosome number of secondary oocyte will be 23X because it is undergoing meiosis, and a smaller first polar body is released. Chromosome number 23X. Now the release of secondary oocyte from the primary oocyte is called as ovulation. Mark it, ovulation does not mean the release of ova. Ovulation simply means that a secondary oocyte is being released from the primary oocyte. Now once the secondary oocyte is formed, it will undergo meiosis 2. But again this meiosis 2 is arrested in metaphase, and this division is completed only if fertilization occurs. That means if this female is about to become pregnant, then only will this division be completed, and then what will be released is a mature ovum. Chromosome number 23X and a second polar body. So, coming to the questions. Number 1 question, as I told you, is that when does oogenesis begin? Oogenesis begins between 6 to 8 weeks of gestational age, number 1. Number 2, because oogenesis begins in the gestational life, but it is arrested. So if you cut a cut section of a newborn baby's ovary, what will you find? You will find only primary oocytes, because this division will be completed once the child has attained puberty and not before that. So in the ovary of a newborn female, there will be only primary oocytes. Third question is, when is the number of primary oocytes maximum? The number of primary oocyte is maximum at 20 weeks of gestation, that is in the 5th month of intrauterine life, and at that time their number is 6 to 7 million. Next question, what is the number of primary oocytes at birth? At birth, the number of primary oocytes is 1 to 2 million. What is the number of primary oocytes at puberty? At puberty, the number of primary oocytes is 3 to 5 lakhs. Out of these 3 to 5 lakhs of primary oocyte, it is only 500 primary oocyte which actually mature during a female's reproductive age. Next, and a very hot question is that when is the first polar body released? Now, ideally you should remember all this, but at the time of exams, I know because of the adrenaline secretion which we have, we tend to forget our basics, and then it is a confusion. When is the first polar body released? When is the second polar body released? So for that, if you can remember a mnemonic, PP1 and M2F. I'm very thankful to one of my students for such a nice mnemonic which they have sent me through email. PP1 means that first polar body is released at puberty, that means at the time of ovulation. And first, another P stands for first meiotic division is arrested in prophase, the second P. Next question, M2F. M2F means second meiotic division is arrested in M, that is metaphase, and second polar body is released at the time of F, that means at the time of fertilization. A very helpful mnemonic. Next question is that at the time of ovulation, first question on ovulation, when does ovulation occur? Ovulation, as you know, that in a female menstrual cycle, if she has a 28-day menstrual cycle, ovulation occurs on 14th day. This is if the female's menstrual cycle is regular, that is, it is of 28 days. But just in case female's menstrual cycle is of 30 days or 32 days or 26 days, then you should remember that it is the period between the next menstruation and ovulation which is fixed to 14 days. So for example, if the female's menstrual cycle is of 30 days, then ovulation will occur 14 days before 30 days, and that is on day 16th. Because it is this period which has to remain constant, and that is 14 days. So ovulation will occur on 16th day. If it is a 22 days menstrual cycle, then again this period has to remain constant, and that is 14 days. So ovulation will occur 22 minus 14, that is 8th. On 8th day menstruation will occur. On 8th day, I'm so sorry, ovulation will occur. Next question, as I told you, what is ovulation? Ovulation is the release of secondary oocyte from the primary oocyte. Now, another question is, what is primordial follicle? A primary oocyte which is surrounded by granulosa cells is called as a primordial follicle. Now, during the time of after puberty, when this follicle grows, this follicle undergoes certain stages of development. This primordial follicle will become pre-antral follicle. It will then become an antral follicle, and then it becomes a Graafian follicle. So questions are asked on Graafian follicle. Now, Graafian follicle, it is a primary oocyte. In the center we have a primary oocyte, and it is surrounded by granulosa cells. And theca cells. The outer layer is theca cells. This is a Graafian follicle. Question which they ask on Graafian follicle is that what is the size of Graafian follicle just before ovulation? Just before ovulation, the size of Graafian follicle is 20 millimeters. This is again a very clinically significant fact, because suppose if there is an infertile couple who's come to you and you are testing whether ovulation is occurring in the female partner or not, the best method of knowing whether ovulation is occurring or not is if you directly visualize or see the development of Graafian follicle with the help of transvaginal sonography, and this is called as follicular monitoring. When you do follicular monitoring, you will see that the size of the follicle increases every day till it reaches 20 millimeter size, and all of a sudden, once it has reached 20 millimeter size, all of a sudden the size of the follicle will decrease. Number one, it will become irregular and you will see fluid in pouch of Douglas. If this is happening, this means ovulation has occurred. So the best method of knowing whether ovulation is occurring or not is by follicular monitoring or by directly visualizing the Graafian follicle with the help of transvaginal sonography. Now, coming to what happens after the ova is released, or rather what happens after the secondary oocyte is released from the primary oocyte, that is what happens after ovulation. Now, after ovulation, once this secondary oocyte is released, if this secondary oocyte is not fertilized by the sperm, then this secondary oocyte, the Graafian follicle, it will be converted into corpus luteum. This corpus luteum, questions which are asked on corpus luteum are, number one, what are the hormones which are secreted by corpus luteum? The hormones which are secreted by corpus luteum are, number one, progesterone, which is the main hormone, number two, estrogen, number three, relaxin, and number four, inhibin. So, if the question says corpus luteum secretes? Option A, estrogen, option B, progesterone, option C, both, option D, none. Then we will go for answer C, that is both. But if the question says corpus luteum predominantly secretes, option A, progesterone, option B, estrogen, option C, both, option D, none, then the answer will be progesterone. Next question which they ask on corpus luteum is, when is the maximum activity of corpus luteum seen? Maximum activity of corpus luteum, it occurs 8 days after ovulation. Now here I want to clear a very important concept. Suppose in a 28-day menstrual cycle, this is first day, this is 28th day, then all of us know that ovulation will occur on the 14th day. Now I am telling you that maximum activity of corpus luteum is seen 8 days after ovulation. 8 days after ovulation means 22nd day of menstrual cycle. So either in this options it will be written as maximum activity of corpus luteum occurs 8 days after ovulation, or it will be written as 22nd day of menstrual cycle, and both these options are correct. The third question is, what is the lifespan of corpus luteum in case it is not fertilized? The lifespan of corpus luteum is 12 to 14 days. After 12 to 14 days, that means counting from 14th day onwards, somewhere around 26th or 28th day, this corpus luteum will start degenerating and it will form corpus albicans. Corpus luteum, when initially it is formed, it is grey in color, and later on it becomes, because it has got lipids, carotene, it becomes yellow in color. Corpus albicans on the other hand is white in color. Now, this is if the female or if the secondary oocyte, it is not being fertilized. Now, if it is being fertilized, then we know that the secondary oocyte will form ovum. This ovum, sperm will fertilize the ovum, and what will be formed is a zygote. In this case, what happens to the Graafian follicle? Again, Graafian follicle will form corpus luteum, but then this corpus luteum will not degenerate, because then what will be present? You know, whenever there is pregnancy, trophoblast starts secreting HCG, and this HCG, it helps in maintaining the corpus luteum. Corpus luteum will function maximally if pregnancy occurs at 8 weeks. At 8 weeks, maximum activity will be seen of corpus luteum if pregnancy occurs. And the function of corpus luteum remains the same during pregnancy also, that it is the main source of hormone progesterone in the early weeks of pregnancy. After 8 weeks, placenta starts somewhere around 8 to 10 weeks. Placenta starts taking over the function of corpus luteum, and then the main source of progesterone becomes placenta. Now, this reminds me of two more questions. Very important question is, what is the fertilizable span of an ova? The fertilizable span of an ova is 12 to 24 hours, and the fertilizable span of sperm is 48 to 72 hours. Next question which they ask on sperms is, in which part of the male ductal system does sperm attain motility? Sperms, they will attain motility in the epididymis. Next question which is commonly asked is, what is the time which is taken for sperm capacitation? Now, what is sperm capacitation? Sperm capacitation means that the sperms, they become hypermotile and they attain the ability to fertilize or penetrate the ova or the oocyte. When the sperms attain this ability, that is called as sperm capacitation. And the time which is taken for sperm capacitation, another question. Option A, 2 to 4 hours. Option B, 4 to 6 hours. Option C, 6 to 8 hours. Option D, more than 10 hours. The correct answer is 6 to 8 hours. Don't go by what Datta has to say. It is giving a range 2 to 6 hours. That is not solving our question. Williams and Langhans, both of them specifically mentioned that sperm capacitation takes 6 to 8 hours of time. Fertilization occurred, zygote is formed, and then this zygote, it undergoes cell divisions to form 2 cell, 4 cell, 8 cell and 16 cell stage. The 16 cell stage zygote is called as a morula. Now this morula, it is formed in the fallopian tube, and you know fertilization occurs in the ampulla of the fallopian tube. After spending 3 days in the fallopian tube, morula, on the 4th day, it will enter the uterine cavity. So morula, another 2 questions. Morula enters the uterine cavity 4th day after fertilization. And in which form does zygote enter the uterine cavity? Zygote enters the uterine cavity in the form of morula. 4th day after fertilization, again coming back to the same concept. In a 28 days menstrual cycle, if this is the 1st day and this is the 28th day, ovulation occurs on 14th day. And if this ova is fertilized, fertilization will also occur on the 14th day. Now I am saying 4 days after fertilization. 4 days after fertilization means 18th day of menstrual cycle, morula will enter the uterine cavity. So in the options, either you can have it as 4 days after fertilization, or they can give it as 18th day of menstrual cycle. Now once this morula, it enters the uterine cavity, it will not keep on hanging in the uterine cavity. It will have to attach itself to the endometrium. This process by which the morula attaches itself to the endometrium, that is called as implantation. Now if this is the endometrium, morula, it can either attach itself superficially to the endometrium. This is one way of implantation. Or this morula, it can go deep inside the endometrium and then it can implant. In human beings, it is this type of implantation which occurs, and it is called as interstitial implantation. The questions which they ask on implantation are: number 1, what is the type of implantation which occurs in human beings? As I told you, it is interstitial implantation. Second question which they ask is, on which day does implantation occur? So implantation, it occurs 6 to 8 days after fertilization. Again, 6 to 8 days after fertilization means 20 to 22nd day of menstrual cycle. So implantation will occur between 20 to 22nd day of implantation, that is called as window of implantation. Now, third question is, in which form does the zygote implant itself? Zygote implants itself in the form of blastocyst. I told you that morula will enter the uterine cavity. Once morula has entered the uterine cavity, fluid will fill in its cavity, and then this morula will be converted into blastocyst, and it is in the form of blastocyst that implantation occurs. Now once implantation has occurred, the endometrium is now called as decidua. So decidua is pregnant endometrium. The question which they ask here is, which hormone is responsible for decidual reaction, that is for converting endometrium into decidua, and the answer is progesterone. Coming to the structure of the endometrium, as you know, in non-pregnant females, endometrium, it has got 3 layers. There is a superficial compact layer, then below this compact layer is an intermediate spongy layer. It is through this intermediate spongy layer that the line of separation of placenta runs after delivery, and then the lowermost layer is the basal layer. After delivery, the whole of the endometrium will regenerate from the basal layer of the endometrium. Now once the blastocyst has implanted, it divides the superficial compact layer into 3 parts, as you can see here. the part of the endometrium which lies below the blastocyst, that is part 1. This is called as decidua basalis, and it is this decidua basalis which will form the maternal side of the placenta in future. Then is the part 2. This part 2 is that part of the endometrium which is covering or which is overlying the blastocyst, and this is called as decidua capsularis. And then there is the rest of the endometrium which is lining the rest of the uterine cavity other than the site of implantation, that is 3, and this is called as decidua parietalis. Again, here also there will be decidua parietalis. Now, as the ova grows, this ova, it will bulge into the uterine cavity, and so ultimately this decidua capsularis and the decidua parietalis, it will eventually fuse, and the space between them, which is called as the decidual space, will eventually be obliterated, and this occurs by 4th month of intrauterine life. Decidua parietalis, the other name for decidua parietalis is decidua vera. Now coming to morula. I told you 16 cell stage zygote is called as a morula. This morula, it has got an outer cell layer. Please don't count the number of cells. I am not counting whether they are 16 or not. And there is inner cell which is called as inner cell mass. The outer layer of cells forms the trophoblast. It is this trophoblast which gives rise to amnion, chorion and placenta. Amnion and chorion, they are fetal membranes, and inner cell mass will give rise to the whole of the embryo. Now this trophoblast, on the 8th day after fertilization, trophoblast will differentiate into 2 layers, syncytiotrophoblast, which is the outer layer which has got a syncytium of nucleus, and mononucleated cell layer which is called as cytotrophoblast. It is this syncytiotrophoblast which prevents the penetration, the deeper penetration of the blastocyst into the myometrium, and later on this syncytiotrophoblast, it forms a layer of fibrinoid degeneration which is called as Nitabux layer. So syncytiotrophoblast, or in other words Nitabux layer, prevents the trophoblast from prevents the whole of blastocyst from penetrating into the myometrium. Just in case this Nitabux layer or syncytiotrophoblast, if this is absent, then what will happen? The blastocyst, it will penetrate not only into the endometrium, it will penetrate into the myometrium, and such a placenta is called as placenta accreta. It gives rise to a condition which is called as placenta accreta. Now another thing is, there is a protein which is called as fetal fibronectin protein. This fetal fibronectin protein is secreted by the fetus, and this protein, it acts like a trophoblastic glue. It helps in the trophoblast to attach itself to the endometrium, or it helps the trophoblast to attach to the decidua. This fetal fibronectin protein, this is present in the amniotic fluid before 22 weeks, and then it disappears and it reappears somewhere around 37 weeks. Now if fetal fibronectin protein is present before 37 weeks in the cervicovaginal secretions, this indicates either there is preterm labor or there is premature rupture of membranes. And again, this is a very favorite question, that fetal fibronectin protein indicates either preterm labor or premature rupture of membranes. Now, with this, our basics of reproduction is almost done. What I want to tell you here is some important timings which you have to remember. Number one timing is that I told you at which age can we differentiate ovary and testes. Ovaries and testes, they are first distinguishable by 8 weeks. Number two, external genitalia, they are first formed by 12 weeks, and you can tell the sex of the baby by inspecting external genitalia by 14 weeks. Fetal swallowing begins by 10 to 12 weeks. Fetal breathing movements, they begin by 11 weeks. Fetus starts producing urine by 12 weeks, or in other words by 3 months. And syncytiotrophoblasts and cytotrophoblasts, they differentiate 8 days after fertilization. Next question is fetal growth periods. Now, fetal growth period, there are 3 periods of fetal growth. Immediately after ovulation starts the ovular period. This ovular period, it lasts from ovulation and up till 2 weeks after ovulation. Second period is embryonic period, which is from 3rd week and up till 8th week of fertilization. And then we have the fetal period, which is from 9th week onwards. Questions are asked on embryonic period. Now, it is this embryonic period which has the period of maximum teratogenicity. It is the period of maximum teratogenicity, which means that if this stage a pregnant female is exposed to any drug or radiation, there are maximum chances of congenital malformation in the fetus. Now, here again, one point which you should note is that embryonic period, we are saying it is from 3rd week to 8th week of fertilization. Now, again, this is first day of menstrual cycle. This is 28th day of menstrual cycle. On 14th day, ovulation will occur, and if this female has to become pregnant, on 14th day fertilization will also occur. This means when we say 8 weeks of fertilization, it is starting from this point we have to calculate 8 weeks. Whereas if we talk about gestational age is not calculated from the time or from the day of ovulation or fertilization. Gestational age is calculated from the first day of the last menstrual period. Because if this female becomes pregnant, next time she will not have a period and this will be missed period. So gestational age is calculated from here and it is not calculated from here. So if they say 8th week of fertilization, this means 10th week of gestational age. Again, both the statements are correct. Coming to another very important topic, and that is placenta. Now, human placenta, there are 3 terms which are used to describe human placenta. Number 1 is it is discoid. This means it is disc-like in shape. Number 2, it is hemochorial. That means in human placenta, placenta lies directly in contact with maternal blood. And the third term is deciduate. Deciduate means that it is shed off after delivery. If placenta is not shed off after delivery, that is called as a morbidly adherent placenta or placenta accreta. Weight of placenta at term is 500 grams. And you know that weight of an average fetus is 3000 grams. So if they ask you what is the ratio of weight of placenta to fetus, it is 1:6. Next question is placenta. It is 15 to 20 centimeters in diameter. Now if you see, this is a pregnant female. Now placenta, it has got two sides. One side of placenta is facing the mother, that is called as maternal side, and the other side of placenta faces the fetus, and that is called as fetal side. Maternal side of the placenta, as we've already discussed, is formed by decidua basalis. The fetal side of the placenta is formed by trophoblast. Now, coming back to the same thing, let's go back to where a blastocyst implants itself in the endometrium. This is the uterine cavity. This here, blue color, is the endometrium. The pregnant endometrium is called as the decidua. This here is a blastocyst. The outer layer of blastocyst, as you know, is syncytiotrophoblast, and just below the syncytiotrophoblast is cytotrophoblast. Now, if I am cutting a cut section here, this here is the decidua, blue colored. Then we have the blastocyst. Outer layer of blastocyst, as we know, is called as syncytiotrophoblast. Below the syncytiotrophoblast is a layer of cytotrophoblast. And just below it will be fetal mesoderm, extra embryonic mesoderm of the fetus. In the extra embryonic mesoderm of the fetus, there will be fetal blood capillaries. And in the decidua, there will be spiral arteries. These spiral arteries, they have got maternal blood. Now, for the formation of placenta, villi are formed, which are called as chorionic villi. These chorionic villi, they are formed. How they are formed? This is something which we dealt in embryology. For the formation of chorionic villi, in the syncytiotrophoblast, vacuoles will appear. Vacuoles appear in the syncytiotrophoblast, which are called as lacunae. And you know, just below the syncytiotrophoblast is a layer of cytotrophoblast. Decidua. Now, once these lacunae, they appear in the syncytiotrophoblast, the blood vessels which are supplying the decidua, the spiral arteries, they open into this lacuna and maternal blood fills these lacuna. So, lacuna are filled by maternal bloods. Initially, these lacunae, they are separated by syncytiotrophoblasts, but in order to support them more, cytotrophoblast also comes in between. So now these lacunae, they are separated by syncytiotrophoblast. This white here is syncytiotrophoblast and cytotrophoblast. Such a structure is called as a primary villi. Now, once a primary villi is formed, the extra embryonic mesoderm, which is below the cytotrophoblast, that will also come in between. Lacuna with maternal blood, decidua, cytotrophoblast, and just below the cytotrophoblast is black colored extra embryonic mesoderm. Such a structure is called as a secondary villi. And now, in the later stages, I told you that extra embryonic mesoderm, it has got blood vessels, fetal blood vessels. And now fetal blood vessels will also come in between, and then this structure is called as a tertiary villi. The lacuna, which are separated by syncytiotrophoblast, cytotrophoblast. Then we have extra embryonic mesoderm, and below the extra embryonic mesoderm there are fetal blood capillaries. This over here was the decidua, and this lacuna is filled with maternal blood. This is called as a tertiary villi or a chorionic villi, and the placenta, the basic unit of the placenta is a chorionic villi. The question which they ask here is maternal blood and fetal blood, they are separated in the placenta by. As you can see, maternal blood which is filling the lacuna is separated by this black colored fetal blood capillaries by number 1, this white space here, syncytiotrophoblast. Number 2, cytotrophoblast, the red colored cells. Black colored cells, extra embryonic mesoderm. And the fetal capillary endothelium. Together these structures are called as placental barrier or placental membrane, and they separate the maternal blood and fetal blood in the placenta. Another thing which we should note here is that when the decidual arteries, they open into the lacuna, at that time these are the spiral arteries which are opening into the lacuna. This is syncytiotrophoblast and the cytotrophoblast. When the decidual arteries, they open into the lacuna, at that time their capillary endothelium is replaced by trophoblast in order to convert them into low resistance vessels. The capillary endothelium is replaced such as they are converted into low resistance vessels, and this is called as trophoblastic invasion. There are two phases of trophoblastic invasion. First invasion occurs before 12 weeks, and then there is a second round of invasion which occurs between 12 to 16 weeks. If there is incomplete trophoblastic invasion, this results in pregnancy induced hypertension. So the most common factor which we say which is responsible for pregnancy-induced hypertension is incomplete trophoblastic invasion of these arteries. Now, have you understood how a chorionic villi is being formed? So, if this is clear, we are going back to our blastocyst stage where it has implanted itself in the endometrium. This was the uterine cavity. This blue color here is the endometrium or the pregnant endometrium, which is called as the decidua, and this red colored here is the blastocyst, and chorionic villi have formed from the trophoblast. So, there are chorionic villi. Now, these chorionic villi, they are very much abundant at the place where the blastocyst implants, and this is called as chorion frondosum. Whereas the chorionic villi which are formed in the abembryonic pole, that is the pole which is opposite to where the embryo is there, at that place chorionic villi slowly they start degenerating, and that is called as chorion levae. So, placenta, it is formed, the maternal side of the placenta is formed by decidua basalis, and the fetal side of the placenta is formed by the trophoblast, and which part of the trophoblast? By chorion frondosum. Whereas this part, the chorion levae, this will lead to the formation of fetal membrane, that is chorion. Dynamics in the placenta. The total amount of blood which flows to the placenta is 500 ml, and the amount of blood which flows in the intervillous space is 150 ml per minute. The blood volume of the blood or the rate of exchange in the intervillous space is 500 ml per minute. Now, other questions which they ask on placenta are: number 1, which is the tumor which most commonly metastasizes to placenta? And the answer is melanoma. Most common lesion of the placenta are placental infarcts. A number of placental infarcts, if many placental infarcts are seen, this means either there is pregnancy-induced hypertension, or it can also mean that there is antiphospholipid antibody syndrome. Then, in which condition is the size of the placenta increased? That is placentomegaly. Placentomegaly, it is seen in case of twin pregnancy or multifetal pregnancy. It is seen in case of diabetes. It is seen in macrosomia. It is seen in syphilis. On the other hand, a small sized placenta is seen in post-dated pregnancies. It is seen in case of IUGR, and it is seen in case of placental infarcts. Coming to abnormalities of the placenta. In the abnormalities of the placenta, number 1 abnormality is when a small part of the placenta detaches from the main lobe but remains connected with the help of blood vessels. This is called as a succinturiate lobe, and such a placenta is called as a placenta succincuriata. Next abnormality is a circumvallate placenta. Now, I have already told you that placenta has got 2 sides, fetal side and maternal side. Now, normally the fetal side and the maternal side, they are equal to each other, and the placenta is disc-like in shape. Suppose if the maternal side of the placenta is bigger than the fetal side, then this maternal side of the placenta will enclose the fetal side in the form of a ring, and a depression is seen in the fetal side of the placenta. Such a placenta is called as a circumvallate placenta. In case of circumvallate placenta, The fetal side of the placenta is surrounded by a ring, and that ring is composed of a double layer of amnion and chorion. Circumvallate placenta can, number one, lead to antepartum hemorrhage because the maternal side of the placenta is unsupported. It can lead to antepartum hemorrhage. It can lead to intrauterine growth retardation, and it can lead to preterm delivery. That means it can lead to prematurity in the fetus. Condition, that is morbidly adhered placenta. Now I told you that human placenta, it is deciduate. This means that after delivery it is shed off. In a few conditions this placenta is not shed off after delivery, and then it is called as a morbidly adherent placenta or placenta accreta. In case of placenta accreta, the problem is that the decidua basalis is absent, and I told you that it is the syncytial trophoblast which prevents the deeper penetration of the blastocyst into the myometrium. This syncytial trophoblast, later on it forms the Nitabux layer. Now if syncytial trophoblast or Nitabux layer is absent, blastocyst can penetrate into the myometrium, and that can lead to the formation of morbidly adherent placenta. So the second problem is Nitabux layer is absent. Now morbidly adherent placenta, it is of three types. Number one is placenta accreta. In placenta accreta, the chorionic villi, they are superficially attached to the myometrium. Then we have placenta increta. Increta means that the chorionic villi, they invade the myometrium. And last is placenta percreta. Percreta means उन्होंने myometrium को पार कर दिया, percreta, and so now the chorionic villi will reach the level of serosa. So the chorionic villi, they are attached to serosa in case of placenta percreta. Risk factors for placenta accreta. Risk factors for placenta accreta are, number one, whenever there is defective endometrium, and defective endometrium can occur if there is a scar in the uterus. So number one risk factor is previous caesarean section scar. Number two, previous myomectomy scar. Number three, previous hysterotomy scar. Number four, if you have done excessive DNC, excessive curettage during MTP. Number five, if there is present placenta previa. And number six, if there is increased maternal age and increased maternal parity. The question which they ask here is, all of the following are risk factors for placenta accreta except option A, previous caesarean section scar, option B, hysterotomy scar, option C, myomectomy scar, option D, previous placenta previa. And most of the students after the class, they will come and say the answer to this question should be none and it is a dummy question. No, it is not a dummy question. Please read the options very carefully whenever you are answering a question. Present placenta previa is a risk factor for placenta accreta and never previous placenta previa. The two most important risk factors for placenta accreta are present placenta previa and previous caesarean section scar. If there is any female, any pregnant female who has come to us with placenta previa and she has history of previous caesarean section, always the possibility of placenta accreta should be kept in mind. Ideally or generally, the diagnosis of placenta accreta is made after delivery when the placenta fails to separate. But if there is a female who has placenta previa with a previous cesarean section scar and you are anticipating placenta accreta, in such females, the diagnosis of placenta accreta can be made, number one, by ultrasound. In ultrasound, generally below the level of placenta, you see a sublucent zone, below the placenta you see a sonolucent zone which represents decidua basalis. In case of placenta accreta, that decidua basalis will be absent. And second, or the best method of diagnosing is by doing a Doppler. Now, coming to the management of placenta accreta, if placenta accreta is seen focally, that means there is only a small part of the placenta which is firmly attached, then you can do manual removal of placenta. Now, for a manual removal of placenta, you should always remember that the uterus should be contracting when you are removing the placenta in piecemeal, because when you are removing the placenta manually, it can be that the uterus is so soft that you cannot distinguish between the uterus and the placenta, and besides removing the placenta, you also remove the uterus. So this means this procedure should never be done under GA, and this is another question. Because uterus should be contracting when you are doing this procedure. But if whole of the placenta is placenta accreta, if there is a complete placenta accreta, then you manage it by doing a hysterectomy. Hysterectomy is the best option for treating placenta accreta. These days they are also trying to do conservative management. In conservative management, they let the placenta be inside the uterus and give the patient high dose of antibiotics, and you give methotrexate. This methotrexate, it brings about autolysis of the placenta. Monitor such patients by measuring beta HCG levels. But then again, there are high chances of infection and there are high chances of a secondary PPH, or there are high chances of placental polyp being formed if you are doing this technique. After placenta, another important topic which we have to cover today is umbilical cord. Now, umbilical cord, normal length of umbilical cord is between 30 centimeters to 100 centimeters. If umbilical cord is less than 30 centimeters, then it is called as a short cord. Average length of umbilical cord is 55 centimeters. Now, umbilical cord, in the initial phases of development, umbilical cord, it has got two arteries and two veins. Left artery, left vein, right artery, right vein. In the later stages, right vein disappears and left is left behind. So when a child is born, umbilical cord, it has got 3 blood vessels. In a few conditions, there is a single umbilical artery which is seen. Many questions are being asked these days on single umbilical artery. Coming to single umbilical artery, now about 1/4 of all infants who have got single umbilical artery, they have got associated congenital anomalies. If there is a single umbilical artery, there are high chances that the fetus will have renal anomalies, number 1, limb reduction defects, number 2, or it may be aneuploid fetus, and the most common is trisomy. Single umbilical artery, it is more common in females who have diabetes, in twin pregnancies, if the female has epilepsy, antepartum hemorrhage, preeclampsia, oligohydramnios, and polyhydramnios. So this is what we have to remember on single umbilical artery. There were many questions which have been asked lately on single umbilical artery, and there they write that single umbilical artery does not have any effect on the fetus. No, if there is a single umbilical artery, there are high chances that the fetus will be having congenital anomalies, or trisomy. Now, coming to how the cord is inserted on the placenta. If this is the uterus, this is the placenta, the umbilical cord and the fetus. Now and this fetus is surrounded by fetal membranes, that is amnion and chorion. Now normally the umbilical cord, it is inserted in the center of the placenta, and this is called as central insertion of the cord. This is normal. In a few cases, the umbilical cord is inserted at one side of the placenta, then it is called as marginal insertion of the cord, and such a placenta is called as a battledore placenta. And in few remote cases, the umbilical cord is first attached to the membranes, the fetal membranes, that is amnion and chorion, and then it is attached to the placenta. This is called as velamentous insertion of the cord. Velamentous insertion of the cord gives rise to a very grave condition which is called as vasa previa. Now what is vasa previa? Suppose this is a very diagrammatic representation. If this is the fetus, this is the umbilical cord. Suppose the cord is first attached to the membranes and then it is attached to the placenta. And if this cord passes over the region of internal os, then what will happen? When the internal os will dilate, the umbilical cord will get damaged. This umbilical cord, it has got umbilical artery and umbilical vein. That means it has got fetal blood vessels. So what will happen? The fetal blood vessels, the umbilical artery and the umbilical vein will start bleeding. And therefore, in case of vasa previa, the blood is of fetal origin. That is first thing which we have to remember. Second thing is that because here whatever blood loss is occurring is directly from the fetus, this condition has got a very high perinatal mortality rate. The rate of maternal mortality is less in this condition. The rate of fetal mortality is very high. The only management of this condition, the only treatment which we have to do here is a cesarean section. If you have diagnosed this condition antenatally, what is the method of diagnosis? By Doppler. If by Doppler you have diagnosed this condition antenatally, you should do a planned cesarean section, and if this condition is not diagnosed antenatally, it is diagnosed at the time of labor, within minutes you have to do emergency cesarean section, because otherwise you will leave you are going to lose the fetus. Now, how are you going to know that the blood which is coming out of the mother's vagina, whether it is maternal blood or whether it is fetal blood? That means whether this condition is placenta previa or whether it is vasa previa. For this, we utilize the property of the blood, and that is fetal blood vessels have got fetal blood, and fetal blood has HbF, fetal hemoglobin. Fetal hemoglobin, a special characteristic of fetal hemoglobin is that it is resistant to acids and alkali. On the other hand, maternal blood has got HbA. HbA is sensitive to acids and alkali. So whatever blood is coming out of the mother's vagina, you take it in a test tube, you add reagent, and the reagent here is potassium hydroxide. If this blood hemolyzes, that means if the color changes to brown, if there is hemolysis and the color changes to brown, this means it is HbA, that is there is maternal blood or placenta previa. But if the blood remains like this, if it remains pink in color and there is no hemolysis, this means it is HbF, that is fetal hemoglobin. That means the blood is of fetal origin and the condition is Vasa previa. This test is called as Singer's alkali denaturation test. Now, I told you that umbilical cord, it has got umbilical artery and umbilical vein. So, coming to a few questions which are asked on umbilical artery and umbilical vein. Umbilical vein has got oxygenated blood, whereas umbilical artery, it has got deoxygenated blood. Oxygen saturation in case of umbilical vein is 70 to 80%, whereas in umbilical artery it is 50 to 60%. Then pressure in umbilical vein is 10 millimeters of mercury, whereas in umbilical artery it is 60 millimeters of mercury. This is what we have to remember about umbilical artery, umbilical vein, umbilical cord, vasa previa. Now, because we have done umbilical artery, umbilical vein, I think it is important here to know about fetal circulation. So, coming to fetal circulation, first thing which we should know about fetal circulation is that in the fetus, the site of oxygenation is not lungs, the site of oxygenation is placenta. From the placenta, oxygenated blood is carried by umbilical vein. Now, this umbilical vein brings oxygenated blood from the placenta to the fetus. Some part of this blood will go through the substance of the liver and then reach inferior vena cava, but majority of it via ductus venosus reaches inferior vena cava. So, the blood which is carried by inferior vena cava is fairly rich in oxygen. Now, this oxygenated blood, with the help of inferior vena cava, it goes into the right atrium. From the right atrium, this blood by the way of foramen ovale, it will reach the left atrium. This blood which is reaching the left atrium is again an oxygenated blood. Now the blood, some part of this blood which is coming from the inferior vena cava into the right atrium, it gets mixed with the deoxygenated blood which is brought by superior vena cava into the right atrium, and this blood, the blood of superior vena cava and inferior vena cava, it gets mixed and it reaches the right ventricle. Now from the right ventricle, this blood which is not very much oxygenated, it is rather a deoxygenated blood, this will, with the help of pulmonary artery, it will reach the lungs. Now from the lungs, with the help of pulmonary veins, the blood will reach the left atrium. Now the blood which is reaching the left atrium, the blood of pulmonary vein is deoxygenated and the blood of inferior vena cava which was bypassed by foramen ovale is oxygenated. So again left atrium, the blood is fairly oxygenated and this reaches left ventricle. Now the blood which was reaching the right ventricle by the way of pulmonary artery reached the lungs. That was one portion. The other portion of that blood, with the help of ductus arteriosus, it goes to the aorta. Similarly, the blood which is reaching the left ventricle, from here a part of this blood by the way of subclavian and carotid artery, it will reach the brain and the upper limbs. The blood from the left ventricle with the help of subclavian artery and carotid artery reaches the brain and the upper limbs. And once this blood has reached brain and upper limbs, the deoxygenated blood from the brain and the upper limbs is carried by the superior vena cava back into the right atrium here. So the superior vena cava brings the deoxygenated blood from the brain and the upper limb back into the right atrium. Now the blood from the left ventricle, again I told you it is divided into two portions. One is reaching the upper limb with the help of subclavian and carotid arteries, and the rest of the blood, it gets mixed with the blood which is coming from the right ventricle. With the help of ductus arteriosus, it will go into the aorta. Now from the aorta, with the help of umbilical arteries, blood will go back into the placenta for oxygenation, and it will also supply the lower limbs. From the lower limbs, the deoxygenated blood is carried by the inferior vena cava back to the heart. This is how there is fetal circulation. Now what happens at the time of birth? At the time of birth, the umbilical artery will constrict, so that now whatever blood fetus has got, it does not come to the placenta. Placenta is gone after birth. Umbilical artery will constrict. Similarly, umbilical vein and ductus venosus, they will also constrict. But this happens a little later than the constriction of the umbilical artery, so that whatever blood is there in the placenta, it goes to the baby by means of inferior vena cava. It goes back to the fetus. So umbilical artery will constrict first, followed by umbilical vein and ductus venosus. Then once the baby is born, the site of oxygenation now is lungs. Now once the site of oxygenation is lungs, the blood which is carried by the pulmonary artery, which was deoxygenated, which was not that much oxygenated, will get oxygenated in the lungs, and so pulmonary vein is going to carry oxygenated blood into the left atrium. The volume of blood which is reaching the left atrium now is much more than the volume of blood which is reaching the right atrium. That is why the pressure in the left atrium increases more than the pressure in the right atrium, and this leads to the closure of foramen ovale. So the foramen ovale is closed and the ductus arteriosus is also closed. So this is how we have the adult circulation. Now what happens to umbilical artery, umbilical vein, ductus arteriosus and ductus venosus? So coming to the remnants of these fetal structure in adults. Fetal structure and adult remnant. Umbilical artery. Umbilical artery forms the median umbilical ligament. Umbilical vein forms ligamentum teres of the liver. Ductus arteriosus will form ligamentum arteriosum. And ductus venosus will form ligamentum venosum. These two are very easy to remember. Ductus arteriosus will form ligamentum arteriosum and ductus venosus will form ligamentum venosum. The only confusion is between umbilical artery and umbilical vein. So I have a very good way of remembering it, and that is umbilical artery forms median umbilical ligament, that is AMUL, AMUL. Artery forms the median umbilical ligament. So now this table is very easy to remember. Similarly, next important question is that there are few structures, there are few named structures which we have to remember, and in which organ they are found, that is what we have to remember. So coming to the named structures which you have to remember. Named structure and the organ where it is found. Number one named structure is Hofbauer cells. Hofbauer cells, they are phagocytic cells which are found in the placenta. Second is Nita-Buch's layer. Nita-Buch's layer is a layer of fibrinoid degeneration formed by the syncytial trophoblast, and again it is found in the placenta. Number 3 is Wharton's jelly. Wharton's jelly, it is the connective tissue of umbilical cord. Number 4 is folds of Hoboken. Folds of Hoboken, again they are transverse folds which are found in umbilical cord. And number 5 is Peg cells. PEG cells, a very favorite question. It is found in fallopian tube. So we have discussed in detail about placenta, about the umbilical cord. After the umbilical cord, you know that the fetus is surrounded by the fetal membranes, that is the amnion and the chorion. About amnion and chorion, you have to remember that chorion is the outermost layer, and chorion, it is formed by chorion levae, that is, in other words, it is formed by the trophoblast. Coming to amnion. Now, most of the tensile strength of the fetal membranes, that is due to amnion. This is the first question. Second question, earlier it was believed that amnion is developed from trophoblast, but now it has been proven that amnion is derived from fetal ectoderm. This is what Williams 13th edition specifically mentions. And number 3 point about amnion which we have to remember is that amnion does not have any blood vessels or lymphatics. Now, below the amnion and the chorion, the fluid which is found, that is called as the amniotic fluid. So, coming to amniotic fluid. A very important topic. Number 1 question on amniotic fluid is, what is the pH of amniotic fluid? The pH of amniotic fluid is between 7 to 7.5. This is very important. Why it is important is because in case of premature rupture of membranes, what is premature rupture of membranes? Premature rupture of membranes means when the membranes rupture before uterine contractions. Normally the membranes, they rupture after full dilatation of the cervix, but just in case labor has not begun and membranes rupture, that is called as premature rupture of membranes. Now, premature rupture of membranes, it can either occur beyond 37 weeks, then that is called as term PROM, and if it occurs in less than 37 weeks, that is called as preterm PROM. Now, whenever membranes rupture, the female will complain that there was a sudden gush of liquid which came out of her vagina. If there is this typical history of a sudden gush of liquid which is coming out of a vagina, then there is no confusion. The confusion arises when the membranes have not ruptured completely, but there is some leakage from the membranes. In such a case, there will be just small amount of discharge which will be coming out of the vagina, and then we have to know whether this discharge is the increased vaginal discharge of pregnancy or whether it is amniotic fluid. And that is when the pH of amniotic fluid comes into use. In such a case, what we do is called as a nitrazine test. Nitrazine test, it is based on the principle that the pH of amniotic fluid is alkali and it is between 7 to 7.5, whereas the pH of vaginal discharge is acidic and it is between 4 to 5.5 with an average of 4.5. Now,